The uniqueness of lung transplantation compared to other thoracic surgeries regarding acute and chronic pain management arises from several elements. The complex nature of surgery, extensive surgical incisions and pleural manipulations, and the necessity for multiple chest tubes. An adequate and strict analgesic regime is paramount to preclude postoperative complications, enhance recovery after surgery, and improve respiratory mechanics. Particularly in these respiratory crippled patients who have just been transplanted with new lungs exposed to a significant bio and atelecto trauma. Another point that should be mentioned is the emerging practice of intraoperative use of ECMO. While not yet adopted as a standard practice, its use is increasing in many centers worldwide. The use of ECMO raises critical safety concerns due to the necessity of systemic anticoagulation therapy in the case of some regional analgesia modality. The role of regional analgesia in general thoracic surgery is well established. However, regarding lung transplantation, there is limited literature, which is mainly relies on few case reports and studies with a low level of evidence. Over the years, a long quest has been made to find the ideal analgesic modality. However, standardizing an analgesic protocols remain challenging since no single approach can meet all needs. Basically, there are three surgical approaches: median sternotomy, thoracotomy, and clamshell incision. Thoracic epidural analgesia is traditionally considered the gold standard for post-thoracotomy pain control. It is suitable for all surgical approaches since it is the only modality that provides bilateral coverage of the whole chest wall. The evidence on thoracic epidural in lung transplantation is based on three retrospective studies. It reduces opioid consumption, ventilation time, postoperative pulmonary complication, ICU and hospital stays, and mortality rates. The main drawbacks are procedural failure and spinal epidural hematoma. Hence, the optimal timing of its placement in the case of ECMO remains unclear. On the one hand, preoperative placement raises concern regarding spinal epidural hematoma. On the other hand, postoperative placement is challenging due to the potential for neurological injury in a sedated patient and the technical difficulties in positioning a ventilated patient. Thoracic paravertebral plain block is another option. The evidence is based on one retrospective study. Its efficacy and limitations are equivocal to thoracic epidural, but with a safer hemodynamic profile. Other modality is the erector-spine plain block, which covers the posterior and anterolateral hemithorax with unreliable anteromedial coverage. The evidence is based on two case reports, which found it to decrease opioid consumption. Still, its use remains questionable with anticoagulation. A relatively new analgesic modality, which is gaining popularity, is intercostal nerve cryoanalgesia. The data is based on three retrospective studies. Its main advantages are immediate and long-term analgesia. It also eliminates the risk for local anesthetic systemic toxicity. The main drawbacks are the unpredictable duration of action and concerns about the development of neuralgia. Lastly, serratus anterior plain block is another alternative. The evidence in lung transplantation is based on two case reports. Its main advantages are that it is superficial and simple blocks. It is suitable for the anticoagulation patient and easy to perform without the need for repositioning. However, it should be mentioned that this provides only unilateral anterolateral coverage. Therefore, a parasternal intercostal plain block should be considered in case of a clamshell incision to provide an anterior medial coverage.
In our institution, lung transplantation is performed using clamshell or hemiclamshell incision. In the past, we mainly relied on thoracic epidural and systemic analgesia as a pain management strategy. However, a new institutional protocol requiring ECMO for all lung transplantations has recently been implemented. Though this change improved patient safety and surgical outcomes, the need for systemic anticoagulation during ECMO raised critical safety concerns regarding spinal epidural hematoma. These concerns diverted pain management mainly towards systemic analgesia, resulting in unsatisfactory results. Recognizing the importance of an individualized multimodal approach that combines both systemic and regional analgesia, we adopted a new pain management protocol. We started to perform an ultrasound-guided single-shot superficial parasternal intercostal pain block and the insertion of serratus anterior plain catheters. Based on our experience, this approach seems to be a safe alternative to thoracic epidural in this context, as reflected by decreasing opioid consumption and allowing for early extubation. We are currently in the final steps of a retrospective analysis of the cases, which hopefully will be published soon. Adequate pain control following lung transplantation is essential. The anesthesiologist should tailor an individualized multimodal approach from the available toolbox, based on surgical and patient characteristics, and according to the experience and institutional needs.